Hello guys, welcome to 3A Medicine. Today we are going to discuss about aortic regurgitation. So, what is aortic regurgitation? It is the regurgitation of the blood from aorta to left ventricle during diastole. So, regurgitation of blood from the aorta to left ventricle during ventricular diastole. Now, let's see the etiology. The etiology is broadly classified into aortic valve problems and aortic root problems. The most common cause of the aortic valve problem is this rheumatic heart disease. So, this is the most common cause. What is the other causes? The other causes are the bicuspid aortic valve, the infective endocarditis, ruptured sinus of Valsalva, Takayasu arteritis, etc. In aortic root problems, there is Marfan syndrome, severe hypertension, syphilis, ankylosing spondylitis, osteogenesis imperfecta, etc. So, let's move on to pathophysiology. Let me draw a diagram. So, this is the left atrium, this is the left ventricle, and this is aorta. These are the aortic valves. Okay. What happens in aortic regurgitation? There is a regurgitation of blood from the aorta to left ventricle. So, the blood regurgitates from the aorta to left ventricle. The left ventricle also receives blood from the left atrium. So, blood from the left atrium also comes to the left ventricle. So, what happens? There is a volume overload. Why? Because there are both regurgitated blood as well as the left atrial blood. So, there will be a volume overload. So, to compensate that, there will be left ventricular dilatation. So, there will be left ventricular dilatation. And sometimes there will also be eccentric hypertrophy. Okay, guys. Now, what happens? There is an increase in left ventricular end diastolic volume because there is a regurgitation of blood. So, what happens? During the next systole, there will be an increase in cardiac output. So, there will be an increase in cardiac output. What happens if there is an increase in cardiac output? There will also be increase in systolic blood pressure. So, there is increase in systolic blood pressure. So, tell me guys, what happens to diastolic blood pressure? Yes, the diastolic blood pressure is decreased. Why? Because during the diastolic phase, there is a regurgitation of the blood. So, there is a decrease in diastolic blood pressure. So, what does this mean? So, the pulse pressure is Y. So, what is the blood pressure? Systolic blood pressure minus the diastolic blood pressure. So, the pulse pressure is Y. Okay. Now, let's move on to clinical features. First, let's see symptoms. So, what are the symptoms? There is left ventricular failure. So, there will be dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. There will also be chest pain. Why? The chest pain is due to increased myocardial oxygen demand by the eccentric hypertrophic muscles. So, there will also be chest pain. Now, let's move on to signs. So, what are these signs? I will explain. So, first one is the Corrigan's neck sign or dancing carotids. There is a prominent carotid pulsations in the neck. You can see in the patient. What is the Quincke's sign? In patient with aortic regurgitation, take his finger and apply mild pressure over his nail bed. You can see the diastolic blanching of the nail bed as well as you can feel the pulsations. That is Quincke's sign. What is de Musset sign? De Musset sign is the head nodding with each heartbeat. What is Durosis sign? Let me explain with a diagram. So, this is femoral artery. This is the diaphragm of the stethoscope. If you compress the distal part of the femoral artery, you can hear a diastolic murmur. So, distal part of femoral artery, if you compress, you can hear diastolic murmur. This is Durosis murmur. So, what is Durosis sign? You can also hear systolic murmur when you compress the proximal femoral artery. So, if you compress proximally, you can hear systolic murmur. So, that is Durosis sign. What is Trabe's sign? So, Trabe's sign is the pistol shot femorals. A sharp bang heard on auscultation over the femoral arteries with each heartbeat. Okay. What is Hill's sign? The systolic blood pressure in the upper limb is at least 40 millimeters of mercury more than the lower limb. For example, in the upper limb, if the systolic blood pressure is 120 millimeters of mercury, in the lower limb, it may be 80 millimeters of mercury. So what is collapsing pulse? It is also called as water hammer pulse. If you ask the patient to raise his hand and feel his radial pulse, you can feel this rapid upstroke and high volume pulse followed by a rapid downstroke and low volume. What is pulsus viscerans? This is a pulse with double peak. This is also seen in severe aortic regurgitation. What is Muller's sign? It is the pulsations of the uvula. Lighthouse sign is nothing but the alternate flushing and blanching of the forehead. Becker sign is the visible pulsations of the retinal artery, and Rosenberg sign and Gerhard sign is nothing but the systolic pulsations of the liver and spleen respectively. Okay, how will be the apical impulse? The apical impulse will be hyperdynamic. Impulse. Let's see auscultatory findings. So this is S1, this is S2, and this is S1. S1 is due to isovolumetric contraction and S2 is due to isovolumetric relaxation. We all know isovolumetric contraction and isovolumetric relaxation. What all murmurs you can hear? First, you can hear early diastolic murmur due to aortic regurgitation. So early diastolic murmur due to aortic regurgitation. You can also hear an Austin Flint murmur. Austin Flint murmur. This Austin Flint murmur is due to the fluttering of the anterior mitral leaflet. During regurgitation, the blood will backflow. During that time, it will compress the anterior mitral leaflet, and the anterior mitral leaflet will compress the posterior mitral leaflet. We can also hear S3 due to left ventricular failure. S3 due to LV failure. Okay, let's move on to investigations. Sorry guys, let's move on to investigation. So let's see the ECG findings. There is T-wave inversion and findings of left ventricular hypertrophy. Findings of left ventricular hypertrophy. What all you can see in chest X-ray? You can see cardiac dilatation and sometimes you can see the aortic dilatation. So cardiac dilatation and sometimes aortic dilatation. Now echo. What all can you see in echo? Dilated left ventricle, hyperdynamic left ventricle, Doppler detects reflex. Doppler detects reflex. And we can also do cardiac catheterization. So let's move on to treatment. We can give medical treatment in asymptomatic patients. What all the medical treatment we can give? So medical treatment, we can reduce the afterload by drugs like ACE inhibitors, hydralazine, ACE inhibitors, hydralazine, nitrates, nifedipine. For left ventricular failure, we can give digoxin and ACE inhibitors. For left ventricular failure, we can give digoxin, ACE inhibitors, diuretics, and advise the patients on reduced salt intake. Reduced salt intake. Then when will we do surgery? Indications: when the left ventricular ejection fraction is less than 55% and the left ventricle and systolic volume is greater than 55 ml per meter square. 55 ml per meter square. So what is the surgery? It is the surgical aortic valve replacement. So surgical aortic valve replacement. So today we have discussed about the definition, etiology, pathophysiology, clinical features, auscultatory findings, investigations and treatment. I forgot to mention, in treatment we can also give drugs, like if the cause is syphilis or infective endocarditis, we should give drugs according to its needs. Okay guys, thank you.